Hello, welcome at the hybrid room of the Institute of Cardiology in Warsaw. We have today a case for TAVI. It is 55-year-old lady with porcelain aorta after the radiation of the chest. And what we would like to do and to present you today is to do a core valve with femoral access, core valve 26 millimeter valves, with the use of the protective device Claret. With me is Professor Marcin Demkow, Dr. Maciej Dąbrowski, anesthesiologist, Dr. Piotr Zaśko, and echocardiographyst Professor Piotr Szymański, and also is a proctor for the Claret because it is for us a new device. Marek Jalówka, who will guide the procedure of the insertion of the Claret device, and also our nurses Basia, Jola, and Danusia. Now I will ask Dr. Maciej Dąbrowski to present the case in details.
Good morning, everyone. Today our case is 55-year-old female who was relatively young as for TAVI procedure. She's with tight aortic stenosis, low logistic Euroscore 2.8% with heart failure class 3. She was diagnosed for Hodgkin's disease and treated with chest radiotherapy. And I would like to turn your attention to the very last point on this slide, porcelain aorta, which was the direct cause of disqualification from surgical management. Echocardiography revealed annulus diameter of 23 millimeters with aortic valve area 0.8 square centimeters, preserved ejection fraction of 65%, and mean aortic gradient 59 millimeters of mercury. It also revealed moderate aortic valve calcification and increased pulmonary artery systolic pressure of 55 millimeters of mercury. On angio-CT scan, we confirmed the annulus diameter. The perimeter of the native annulus was 66 millimeters. We also confirmed the extensive calcification of the porcelain aorta, which you can appreciate on the left-hand side on the picture, and moderate aortic valve calcification. There were no extensive tortuosities or lesions in femoral arteries, and the diameters of both left and right femoral arteries was friendly for implantation device. And here you can appreciate angio for left and right coronaries. There were no relevant stenosis. So here is our strategy. We would like to perform direct core valve 26 implantation with right femoral approach, and due to massive extensive calcification in ascending aorta in relatively young patients for neuroprotection, you would like to perform the procedure with Claret protection device. And now I would like to ask Professor Piotr Szymański for additional presentation of echo examination. Piotr, please.
Fine. So what you see on the first image is the transesophageal echo of the aortic valve, which is heavily immobile with just a minute opening of the leaflets, and also heavily thickened aortic wall, which is one of the main reasons of performing TAVI in this patient. So let's go to the next image over here, which is the color Doppler, just a short glimpse on a huge aortic regurgitation, which adds a gradient and adds to the problem. So we have a complex aortic, both aortic stenosis and aortic regurgitation. Now you see the valve itself, it's a tricuspid valve. It's not as calcified as you might expect in the case of rheumatic valve disease or degenerative one, but this is following radiation therapy. Still, the opening of the valve is very poor, and as I previously said, there is also a significant aortic regurgitation. Altogether, it's a significant aortic stenosis and significant aortic regurgitation that made us perform the procedure. And the gradient itself is quite heavy. You can see the large velocities over 400 meters, and also that confirms that it's the stenosis itself that is severe. Is a relatively low velocity in the LVOT, which trace you can see over here. I'll show it to you in a moment. Just here, it's a little bit over 80 centimeters. So the ratio of the velocity in the aorta to through the aortic valve to LVOT is well over 4. So that makes the stenosis severe regardless of aortic regurgitation. Right, that's the ascending aorta, again with a very heavily, let's say, thickened calcified wall, which is a threat for the embolic phenomenon in case of TAVI, and passing the device through the ascending aorta towards the valve.
So now, like you can see, we have already sheet inserted to the left groin. It is just the 6 French sheet, just for the measurement of the pressure, and also to control what is going on the right side. In the right groin, in the right common femoral artery, 18 French sheet was already inserted, and we have also the 6 French sheet put through the right radial artery, and this sheet will be used to the implementation and to the introduction of the Claret device. So we now have the reference picture of the origin of the innominate artery and left common carotid artery from the aortic arch, which is helpful to maneuver with the Claret system.
So this is the dual filter system from Claret, 6 French compatible, 0.14 guide wire over the wire system, where we have 2 filters that protect the arteries from getting any debris into the brain. One, this is the distal filter that we will deploy. A second, this is the proximal filter that is going to be deployed in the brachiocephalic, that will also protect the right carotid artery. With here, which is the most important part, is this articulating blue part of the catheter that is steerable, with which we will be able to make the right curve in order to enter the left carotid artery. So here right now there are several ports. One is for flushing the distal filter here. This here is for flushing the proximal filter, and this one is just to flush the articulating blue part of the catheter. The idea is to put this prior to any endovascular procedure on the aorta, and this time it's TAVI, the TAVI procedure. Then perform the TAVI procedure, and after that we will retract both filters into the catheter again, and we'll take the whole system out, and then we might have a look what we captured.
Yeah. I'm going with the system now. That's very good.
Jeszcze, chyba. Dobra.
Jeszcze. Jakoś tutaj. O. I think we can now open it. Yes?
You unsheath it, so to say?
Yes.
Yeah, I unsheated the proximal one.
So that's easy.
Yeah, it's easy. It is the easiest part.
Now we have to go back with the blue part.
Yeah, exactly. Through the hole.
Okay, and then we
Teraz
have
zrobić
to
krzywiznę delikatnie.
rotate it and do a curve, but the curve is in another direction.
We
Now
need to
it
twist
will
it.
be good.
Okay. Moment.
Try to do something.
The guide wire.
It's going or not?
Yes, it is.
But it is going to subclavian artery.
Yes, it is. Can we go a little bit w dół, downward?
Down. Okay.
Okay.
It's too much curve. Maybe like this and like this now.
No.
Okay, like this.
No.
Try like this. I will go up with everything.
Not.
But it is too much curve, I know. I know. It's going somewhere or not?
Yes, it is subclavian. I
It
suppose.
is, you think so?
Yeah.
It is subclavian. So maybe more curve on
Yeah.
it. It's too much, like this.
Yes. Now we are.
Now,
You know,
now we are.
the thing is,
Let's-
if we move the whole blue part, just
Yes.
to be
We've-
as on top as possible.
We have
But
to
it
keep the
seems-
filter still
Yeah.
and just pull a part of the blue part, right?
Yeah, yeah. To get it in.
Yeah. Exactly.
Now
Exactly.
it is okay.
But now it's. But
Yeah. That's enough. That's enough.
I think it is enough.
Yes.
Yes.
Now we can go with the.
now we can deploy with the
Deploy the
stylet.
filter. Yeah. Deploy the filter. Deploy the filter. Keep going. Keep going. Keep going. I think it is very nice.
And now we have to move it back again, you know, the blue part again.
Shouldn't we do the angio now? Let's check this
Okay.
out with our orthograph and now we assess because
Okay.
now we
I
cannot.
think that what we can do is probably the optimal position now, because if I will go more, I will lose everything.
Mhm.
So I think it is all I can do.
Okay, let's leave it like that.
Yeah.
Let's do our orthography.
Okay. Yeah, I think it is great.
Looks great.
I think it is great.
Yes, I think so.
We were misleading by this curve,
so
but
nice.
the curve is just under the origin of the both innominate and left carotid common artery. Yeah, but it is not too deep. It is like it should to be,
Exactly.
I think. Okay, so now we are after the introduction and delivery successful of the Claret device, like you can see. And then the next step is to do the orthography to look for the optimal projection for the implantation of the valve. You can see that there is quite big aortic incompetence. It is really significant aortic regurgitation. So we hope that we do the double work. We improve this stenosis and we improve also this regurgitant wave. Okay, so the next step is to use the Amplatz diagnostic catheter. I think Amplatz 1 left.
Why do you do it on ice? Because they just need to know, and they have remember the shape. Oh, okay. And you can.
Amplatz wire already in left ventricle. And the next step is to put a 26 mm corbel valve. Like I said, it will be done without balloon valvuloplasty. We would like to do direct valve implantation. Okay, we have to see what is going on with the filters. But it's going okay. The wire is okay. The wire is okay.
Adjust the projection now.
Yeah, we can adjust the projection to see the like this,
Yeah.
like this. I think it is okay. I think we can do an injection now, yes? Tak, i teraz jest okay. I don't know if you are not too shallow now. A bit too shallow? Okay, I will go a bit down like this. And we can try to start, I think. Okay, I will try to keep it at this second level. It's usually going down a bit, but I think it is okay. I think it is okay now. I think it is okay. Let's look at this for a moment, but well,
Shouldn't be higher.
no, shouldn't be higher, but also shouldn't be lower. So it is in the middle. Okay.
So let's go.
Just keep opening it, yeah. Okay. Do an injection now, okay? Już. Let's open it at this stage. We will have the normal blood pressure. The pressure looks okay. We can do an injection and okay.
Już teraz nie ciągnie, że
Tak.
raczej to luz.
Ale to po wstrzyknięciu.
Po wstrzyknięciu. Okay. I think it is nice. Okay, now we have the pressures in left ventricle and the aorta after the implantation of the 26 mm corbal valve. You can see that the diastolic pressure in the aorta is 50-52 and the end diastolic pressure in left ventricle is 17. So I think that the result is satisfactory. There is something like 10 mm gradient through the valve. Okay, so we can go with this pigtail out, and then we do maybe the final injection. So you have the final injection. The result is, I think, optimal. There is completely no aortic regurgitation or any paravalvular leak. So we will ask Professor Szymański about the assessment of the paravalvular leakage, if there is any.
We are finalizing the procedure. The valve now, you can see it's very nicely expanded. It's very nicely located. You can see the leaflets over here. And I would say that the echocardiographic result is perfect. And you can just see a trace aortic regurg paravalvular over here. It's within the scaffolding of the valves. It will probably either diminish or even disappear in a few days, so we shouldn't be worried with that. So now we switched from transesophageal to the normal vascular probe, and we are looking at the internal carotids over here, at the carotids over here, the device over here. You can see the device and the filter itself. The points over here form a circle. That's the filter inserted into the carotid artery.
Yeah, I think it is a high implantation, but there is also no left bundle branch block. I think this is the ECG is not optimal, so you cannot judge, but it looks that it is not. And there is not paravalvular regurgitation, or maybe a trace. So
the position of the frame was good.
yeah, the position of the frame is optimal. It is like the core valve should be implanted, I suppose. We remove now the Claret system from the patient circulation, and now we try to see if there are any emboli or tissue particles.
And now let's take a look at the distal filter, distal part of the device. We can appreciate at least one large particle, which is actually this huge, and many little debris in the bottom part of the filter. Check out the proximal part of the device. Here we can find many little particles which are located in the membrane, and at least another one large cloth or debris.
That it is a very safe approach to avoid excess of bleeding. Okay, I think it is enough. We can inflate the balloon. Also. It is 8mm balloon. It is 8. So we give something like 4 to 6 atmospheres, no more. And now we can do the closure of the artery with a prostar.